can go on to Dr. Shams, please. We'd like to listen to your talk on congenital glaucoma. And I'm sorry they haven't given me your introduction, so please introduce yourself as well. Thank you.
Good morning. I've been here for the last 45 minutes, and everything what I knew on UVM in congenital glaucoma, childhood glaucoma, that was really ocean of knowledge. I gathered a lot, and now my presentation is quite different from such an UVM and investigations procedure. And this is all about the congenital glaucoma, my little experience in my country. So, lovely child with painful blind eye. So, this is a lightning and thunderstorm in a clear sky, hopeless condition to a parents. Then what next? What to do? We must care the patient. We have to make a plan. We have to take action in time. Congenital glaucoma, how far we have come. I am Dr. Shams Mohammed Numan, Associate Professor, Bangabandhu Sheikh Mujib Medical University, Bangladesh. This is the only medical university which controls all the post-graduation degrees in Bangladesh. I don't have any financial interest doing this presentation. Our challenges in my country. Poor socio-economy is a great challenge. Consanguineal marriage, you know, the congenital glaucoma is 4 times higher due to consanguineal marriage. Lack of knowledge about the glaucoma in the periphery. Excitement over large, beautiful eyes. Some parents are very much excited seeing the large eye in his child. So they think that it's a very good, this is the beauty of his or her child. Fear of surgery. Lack of expert surgeon in different areas of Bangladesh, because we have lack of glaucoma surgeon, but also, and it is really very challenging to find out a childhood glaucoma surgeon in different areas in Bangladesh. Lack of physicians' interest. The reward is not very much good, so very few surgeons used to do this surgery. I am telling about the reality actually. General anesthesia. It's really a challenge in different peripheral areas of our country. A special instrument is needed. This is also a challenge. What are the other challenges? Congenital glaucoma and childhood glaucoma may be associated with the other ocular associations like aniridia, Sturge-Weber syndrome, Neves-Sobota, Axenfeld-Rieger syndrome, Marfan syndrome, Murchison syndrome, and Down syndrome. We do examination under anesthesia, external exam, corneal assessment, refraction, ophthalmoscopy, exam under microscope, tonometry, gonioscopy, and ultrasonography. This is the basic thing we all know. Corneal assessment, we do the horizontal corneal diameter, we try to find out the heavy corneal edema, corneal scar. We do the Parkinsonometry of those patients to see the intraocular pressure. A gonioscopy, we do the surgical gonioscopy with Swan-Jacob and Mori gonio lens. This is one of my patients presented with phacomatosis pigmentovascularis. It's a very rare congenital systemic disorder. Patient has a vascular anomaly all over the body and unilateral corneal edema. And if you will see, there is a large corneal edema, thin sclera. I used to give a triangular incision, triangular flap. Patient was also associated with nevus of Ota, very thin sclera, Now I am doing the trabeculotomy, the most important part with the Harm's trabeculotomy. Sometimes it is very much challenging because it may touch the iris tissues, and as everything is very much vascular, the possibility of bleeding and intraoperative hypoma possibility is more, and ultimately we finish the surgery with a great success. This is another case of very complicated glaucoma patient underwent cataract surgery followed by raised intraocular pressure. I did the tube implantation in such case, arm volume implantation. So sometimes it is very important to see the depth of the anterior chamber and also the thickness of the sclera. I am just covering the tube with the titoplast. I like this. This is another case. I am doing the trabeculotomy. Doing the D block excision with Kelly punch forceps. Now I'm sometimes I used to implant allogen in case of congenital glaucoma. So this is one case where the patient is presented with very enlarged cornea, and the second one is third postoperative day, and right downwards is the left downwards is the seventh postoperative day. So different surgical treatment: goniotomy, trabeculotomy, 360-degree trabeculotomy, trabeculectomy, combined trab and tram, drainage implant surgery, cyclodestructive procedure. In my country, we used to do the trabeculectomy, combined trab and trab, drainage implant, and sometimes you do the cyclodestructive procedure with cyclodiode. This is the most preferred technique so far. In my experience, the success rate is 80 to 90%. But the most important thing is to rehabilitate visually. Correction of refractive error is a challenge. Correction of media opacity, the corneal scar and cataract, orthoptic treatment and amblyopia therapy. Parents counseling is very much important because their help is very much very important to ultimately settle the patient, and it will relieve the anxiety and improve the compliance. This is some of our leaflet which we have produced in our institution for giving to the patient. I think I am recommending every institution to do that. It will really helpful. It contains something about the congenital glaucoma. It should be in the local language, and also different treatment options. Though these are some child's postoperative cases. I used to very much happy to see those smiles. Thank you everybody for your patient hearing. Thank you.
Thank you so much, Dr. Shams. Since we have 5 minutes, Dr. Shams, can we take a couple of questions if anybody has? So session ends in 10 minutes. We have 10 minutes for a discussion, for an interaction. So, Dr. Shams, are all your children usually scarred and opaque corneas? Are you thinking of the not so opaque, doing angle surgery in them to try and avoid the conjunctival?
In my experience in our country, if it is okay, if I see this intraocular pressure is not too much high, cornea is enlarging, I used to do the B scan if everything is fine. Sometimes I wait and I don't do the surgery.
Okay.
I don't do the surgery, but most important challenge is examination under anesthesia, because I don't have any facility to do the UBM in our country. Actually, in the premises where I works, but when I see that the cornea is becoming opaque and patient has some problem and also some photophobia and blepharospasm, and that time I used to do the examination and anesthesia if the intraocular pressure is raised, and also if the I used to see the optic disc, the disc is getting larger, curved disc ratio is getting larger. In that cases, I take the decision for the operation, angle surgery.
For angle surgery
Yes.
as well. And since you said, just one question about consanguinity, since you said there's so much of consanguineous
Yes,
marriages,
yes.
and it's likely to have homozygous disease, which is more severe, would you do any parental counseling and would they listen? I mean, is it possible that, because that's something tricky that
Yes,
we're
yes.
also facing, but
Yes.
though our part of the country,
Yes.
we don't have consanguineous marriages so much, but do they listen? I mean, is parental counseling a part of it now?
Yes, yes,
Okay.
yes. Because when we celebrate the World Glaucoma Day, in different TV talk shows and also in our different forums, it is our common talk that the consanguineal marriage is a very much risk factor for developing of congenital glaucoma. And also in our office, when the patient comes with a baby large cornea, the baby referred to us for a congenital glaucoma. This is our first questions about their marriage. And also we used to just circulate it in different areas. And also in different institutions, we have some videos about very awareness videos about some congenital glaucomas, and it is running in different patient areas, and some advices. So consanguineal marriage, not to do the consanguineal marriage, not to choose such a couple, such planning, it is a routine counseling.
Yeah, so that's important that you
Yes,
already,
yes.
I guess when they have a baby, probably it's easier to tell them that once you have this,
Yes.
your likelihood is more or something else.
Yes.
Because now genetics, at least in India, is getting to be a little more affordable.
Yes, yes, yes.
So we have more evidence to tell them.
Yes.
What.
I have one question.
Yes.
That is in up to which age, at which age group you referred the patient for the keratoplasty?
So if I think the child, see, there's no point in waiting, because if the cornea is opaque, then we lose the chance of vision. So Sirisha is fortunate to have a very robust pediatric cornea service.
Yes.
Most of us don't. But I would want them to do it as early as possible. And
Okay.
like we do the glaucoma as early as possible. Having an opaque cornea in the formative first year of life is not going to do very much if you're going to wait till they're a year old and then do it later.
Yes, yes.
That's my take on it.
Dr. Shirisha, what is your experience?
So if I agree with Sushmita that we have to be very wise in advising who requires a
Yes.
keratoplasty and who would benefit from it. So if the cause is the corneal problem and there is a corneal opacity, especially bilateral, and the child is developing a nystagmus, then that means the baby requires a keratoplasty. There's no point in waiting. So we do it, in fact our corneal surgeons do it as early as 2nd or 3rd month in life. So as early as that, very, very young babies, but the evaluation and follow-up is extremely important. And before we embark on doing a corneal procedure, the parents are actually evaluated and made sure that they agree that they will come back for a follow-up. Very, very important,
Right.
wherever
Right.
they are from. They could be
Yes.
from Gujarat, they could be from, Jammu
Bangladesh.
Kashmir, wherever it is, Bangladesh, wherever it is. In fact, we have children coming from Bangladesh. We tell them, so they take an apartment and they stay here for 2-3 months. Fix everything. Once all the sutures are out, cornea is clear, then you discharge them. So it is very, very important. And because on a weekly basis, when the sutures get loose, we need to keep removing them, make sure, because infiltration and infection is the two major problem apart from glaucoma. So that's very important, number one. Number two, the kind of cases that Sushmita was showing, the Peters anomaly. So the eyes that have relatively clear cornea, when we do a glaucoma surgery, they clear. The contralateral eyes, which also have a lenticular corneal adhesions, there is a procedure, which multiple procedures are there, but of late people are talking about lensectomy or a CPA, where you leave behind a little bit of the attached lens capsule to the posterior corneal defect. And these corneas, what is so interesting is that once you remove the lens attachment to the cornea, cornea automatically clears. In fact, when people told me, the corneal people told me, I never thought that it can actually clear without a keratoplasty. But once they remove that adhesion, be it a complete lensectomy or leave behind that capsule and remove the rest of the lens, the cornea completely clears. Maybe a faint scar, but it clears. So to a great extent, we should be able to save these eyes. But yes, we need to do that at an early stage.
So the hypothesis that they say is that there is abnormal endothelium in the area of the defect. And if that is somehow removed, and the normal endothelium then sort of grows over and clears it. But
so you are just remove that membrane. This is the peeling of the membrane, or like just to cut the membrane?
Cut it. You don't pull it. If you avulse it, the rest of the decimates also can get detached.
Okay.
And even while doing the pupilloplasty, while we have to be extremely careful about not touching the lens, same way with the decimate. So when you're making your first entry with your paracentesis, when trying to get a cleavage plane before you inject the viscoelastic, you should be very, very careful, because I have seen a couple of cases where the decimates completely gets detached, and then you're so comfortable you go and remove everything, including the decimates. So these eyes are very tricky, very tricky. So you have to be careful, especially if it is completely stuck to the cornea.
And very interesting, we are facing another challenge in our country. When we have counseled the patient for the surgery, and the people used to take time, because a very small child will go undergo surgery. So within this time, we put drops, and very interesting, 15 or 20 days patient get better. And for this, patient don't come to our, don't come back. And this is really a great challenge. Okay, patient is responds with medications, so I think he is getting well.
I think first visit to try and tell them that that they will 100% require a surgery, and whatever these medications are only an interim. Very, very important. Otherwise, I totally agree with you. Many times they say the cornea is cleared and why should you come back? And many times you hear the referral doctors who say, let the baby become a little older, you can do the surgery later.
Very
or
common.
a grandmother tells risk of loss of life when you do a surgery at an early age. All sorts of funny things you hear. But I think it's spending that extra 5 minutes to speak to the parents that this is a lifelong problem, and we need to, the earlier we treat, the better it is. So I think a lot depends on the counseling.
Thank you.
Sure. The last, and then we'll hand over to the next IC.
Thank you very much. Actually, I have seen one of your cases during trabeculotomy, bleeding was there, so you put air bubble. In my practice, I feel that during trabeculotomy, sometimes, especially in large corneas or in older children more than 2 years, I find bleeding starting. So is there any tips or tricks to avoid this bleeding? Because actually it is noising during surgery. That is for all of you. If you can
I think the one he showed with bleeding was with the nevus of Ota in the
vascular.
So there, no matter what you do, the minute you're going to cut that sclera, it's going to bleed. So I think you just need to. So one thing that I do is I have a little bit of adrenaline-soaked sponges. So before if you try to cauterize all that abnormal vasculature, nothing's going to happen. Just the sclera. So I just press on it for some time, especially in Sturge-Weber or Klippel-Trenaue or even pigmentovascularis, and then it sort of subsides, and then you do the cautery to the bleeders. That's my take on that.
It's not during trabeculotomy when you go inside by trabeculotomy. Sure. when you go inside or trabeculectomy.
Okay.
So for small children, months children, I didn't face bleeding, but for large corneas, maybe I don't know, maybe the sclera become a little bit behind or something, or for older children also.
Okay.
During trabeculectomy, once I start trabeculectomy, then what I do just cauterization, the opening of the thera, but sometimes works, sometimes not. So
Maybe
that's-
there's a little bit of an iridodylisis at that time, possible.
Probably
that might-
due to thin sclera, sometimes it is very, it is really challenging to diagnose whether it's the iris and ciliary body. When we touch the ciliary body, we may cut the ciliary body. In that cases, extreme hemorrhage can be occurred. So, madam, what's your experience?
I think Sushma has a
We are
comment.
running
then-
out of time.
Yeah, we're running
so
out of
maybe
time.
we
So-
can discuss
Yeah.
out of the session.
Yeah, Sushma, just the last point and then we'll hand over.
I just wanted to ask, what I use is for the surface bleeding, a drop of alpha-GAN.
Okay.
Since the child is under GA, you can monitor the heart rate. That helps in reducing the bleeding at the time of sclera. So a drop of alpha-GAN is what I use.
Thank you.